Hello, I'm Lauren Meffen, speech-language pathologist, lymphedema therapist. Today, I want to really talk with the speech pathologists who are considering head and neck cancer as a specialty. So oftentimes, this is a scary beginning because the anatomy sometimes can feel a little bit overwhelming in understanding the impact that cancer has on swallowing, understanding the impact that cancer has on the voice. But for me, those are two of the most life-changing things that I can do to help my patient. Number one, give them something meaningful to eat and drink or method to do that. And number two, communicate with their loved ones, their grandchildren, their children, their spouses, their medical team. So I always tell my clinical fellows and my students in the clinic, I don't really feel like you get good at this job until your fifth year of doing it. And that's my own personal belief. That was said to me by one of my supervisors in my acute care setting. And when she first said it to me, I was about a second or third year clinician, and I was mad. I was like, what is she talking about? I'm a really good speech pathologist and I've been practicing for 2 years and, I just spent 6 years in school. You are a good speech pathologist, but you have to be able to see to learn. And the only way to do that is to get the years of experience and patients coming through your rotation. So around year 5, in my acute care placement, which is a hospital setting, I realized, wow, there's a lot of patients coming through with feeding tubes who have gone through treatment for cancer and they don't have cancer, but they can't swallow. And then I started asking more questions. And that's where the true learning begins. You have to continue to ask questions as a speech pathologist. You have to believe that you don't know everything. You have to believe that you can speak to your physicians, because all of a sudden I gained the courage to talk with my physicians and team in the hospital. I would walk with them from the 6th floor down to the 3rd floor and talk with them about that particular patient. I would learn their perspective. So first, my recommendation is talk to your doctors. They want your help. They just sometimes don't know how you can help. The next thing I would encourage is understand the role of each physician, right? So these physicians are specialists. Take it from 2 perspectives. The first is your patient's perspective, who tells you that they've talked with 19 doctors. And the second is your perspective, who has to understand my patient has spoken to a radiation oncologist. That doctor is treating their radiation. That patient is going to see that practice 5 days a week in your head and neck cancer patient, okay? Typically, they will see them anywhere from 5 to 7 weeks, depending on the diagnosis that we are going to see side effects with. The second person is an oncologist. That is going to be the chemo physician. They are going to work with that patient once a week to receive medication to shrink the tumor, treat the disease. The other physician involved, who you may or may not run into in the hospital, is the ear, nose, and throat surgeon. That doctor diagnosed the cancer. They came into their clinic, they were referred by their primary, they complained of either a sore throat or difficulty swallowing or this bump on my neck, etc. And that physician diagnosed, typically has done some form of a workup, a biopsy, etc. And they say, okay, you have head and neck cancer, and I need you to now be referred to the rest of the team to get treatment. Okay, so those are your 3 primary specialists who work with your head and neck cancer patient. Now you take all of the additional people. You have a dentist, usually. You have hopefully a speech pathologist, a physical therapist, a dietitian. Oftentimes that's the team approach where they're referred. In a perfect world, every single one of these patients would have mental health support, because this is a very stressful diagnosis, not only for the patient, but also for the family members. They are the ones bringing them to treatments. They're really the ones who are keeping these patients going. So as you start to understand the logistics of this diagnosis, don't be afraid to ask questions. Don't be afraid to start to try to understand which doctor does what. And also know, as a speech pathologist, there's certain times our intervention is helpful and certain times we potentially are not helpful, okay? You'll have to know your timing in this diagnosis. If your patient is receiving 7 weeks of radiation, you're not jumping in with a modified barium swallow study or a Fees swallow study at week 6 of treatment. Why? They're side effects. The side effects are so acute and so significant. Your goal is to keep them swallowing through their treatment at that point. Depending on your facility, they may have a modality where a feeding tube is placed what we call prophylactically versus proactively versus when needed. Our practice that I work most closely with is we do not place a feeding tube until the feeding tube is needed. We believe that you have to continue to swallow, push yourself so that we can continue to swallow after treatment. There's science and literature that says the quicker that feeding tube goes in, the less likely your patient is to return to a swallowing post-treatment, right? So they are more likely to be feeding tube dependent. That's what I'm trying to say. Got a little wordy there, sorry. So we believe and we pull the science that says you have to keep swallowing. I don't care if you are just drinking Ensures Boost, however many the dietitian and the physician say a day to keep your weight on, but you have to keep swallowing. They don't have to swallow solids. Yes, we want them to, but that's not a must in those weeks, 5, 6, 7. Now they're done with their radiation and they have a couple weeks where all those side effects are compiled and they're trying to just make it through the day. The other thing to know is we don't see our patients typically. I'm going to kind of explain this to you. So week 1 is 1 of treatment. Week 7 is 7 of treatment. Then I call them weeks 8 through 12. Okay. So weeks 8 through 12, we do not see our head and neck cancer patients at my clinic. The reason for that is they're resolving with their acute side effects. They're trying to maintain hydration, nutrition. They don't even typically want anything in their mouth or anybody poking and prodding at them. So I will, in the outpatient world, see my patients anywhere from, I call it week 12 to 16, which basically means you've completed your radiation treatment. Now you are 4 to 6 weeks post your radiation treatment. All right. So that's really, or 11 to 15, if you want to be good with numbers, which I'm not. So that's really the important piece for me to educate you as clinicians who are considering becoming a head and neck speech pathologist. So it's an amazing world. It was life-changing for me once I decided that this was something I was so passionate about, because the science behind it is challenging. Not a single patient have I ever treated the same. Each of them has a different comorbidities, different diagnosis that I need to consider before I decide to do my treatment. Each of them has a different support system. Each of them has a different outlook on life. Sure, I have a program and I want my patient to come to my clinic based on the evidence practice, the evidence-based practice that I have been trained in, right? I follow the literature very closely. I am a nerd when it comes to reading head and neck cancer literature. I love it. I love the science behind it. I attend conferences. I'm very up to date in what's happening in the head and neck cancer world when these patients have been treated with chemo and radiation, and the terminology and the side effects. I am real with my patient. I do not give them false hope, but I do give them hope. And I explain that things will be different. So I hope that you will consider taking this journey as part of your career, because it can be life-changing, but you need to do it from the motivation of intrinsic. You need to be passionate. You need to have a higher level of empathy, in my opinion. You're not always going to be paid the best. And that's important for me to say that, because as speech pathologist, sometimes I've learned that people expect a certain dollar amount. Once I decided and I found that head and neck cancer was something I was so passionate about, I didn't care how much I made. I really didn't. And to this day, I don't care how much I make. I want to change the life of my patient. And if that means that I make less of amount than a 16-year experienced speech pathologist, I don't care. So you have to also be willing to kind of make those sacrifices personally if this is something that you want to venture down. If it is, continue to join me as we learn, how did I incorporate a fees into my private practice? How did I move from the hospital to an outpatient setting, to an ear, nose, and throat physician's office, and then to my own practice? So continue to follow this journey with me. I hope that you will be motivated to change the lives of your patients. And please feel free, download below just a few little reminders for us as speech pathologists. Who are which physicians, and how am I going to get to know them better? I'll give you a little homework. Your first homework is pick up the phone, talk to one of them, ask a question, offer a piece of information that you feel could be valuable to their patient. All right? But know your stuff. And if you don't know it, ask. Thank you for joining me. Have a wonderful rest of your day.